Well, hello. Welcome to our event, Cybersecurity in Healthcare, which Matter is co-producing together with accentedge. So I'm Steven Collens, I'm the CEO of Matter. We are a healthcare technology incubator and innovation hub with a mission to accelerate the pace of change of healthcare. Since we launched in 2015, we've incubated more than 1,000 startups, and we have a suite of services to help them at every stage of development. We also run 6 to 8 startup accelerators every year in partnership with large health systems and life sciences companies and payers, associations, foundations, each one focused on 5 to 10 startup companies that are innovating in a particular area of healthcare. We help large organizations innovate more effectively with a suite of education and training services, helping them unlock value through innovation. We are the digital health hub of BARDA's Accelerator Network. BARDA is an arm of the Federal Department of Health and Human Services that's responsible for innovations to improve the country's resilience, which is something we're going to be talking a lot about today, in the event of public health threats. And we host events focused on healthcare innovation, bringing people together to be inspired, to learn, to connect with each other. Today's forum focuses on an issue that is unfortunately hard to escape these days, and that is cybersecurity. Attacks on hospital systems continue to rise, and the hackers continue to become more sophisticated. As one of our panelists, who we're going to hear from in a minute, said to me the other day, we are basically pitting our health systems against some of the most sophisticated hackers in the world, who are in some cases sponsored by or at least colluding with nation states. So what is a health system supposed to do? And with us today, to sort it out, we have 3 experts in the field, some of whom are experts by choice, some of whom have become experts not so much by choice. Joining us virtually, we have John Riggi, who's the National Advisor for Cybersecurity and Risk at the American Hospital Association. He spent 30 years with the FBI and is a nationally recognized expert on cybersecurity. We have his colleague as well, as a Deputy Director with an equally impressive background, Scott Gee. And in the room, we have Dr. Tom Shanley, who's the President and CEO of Lurie Children's Hospital. I know Tom wishes that he did not have the expertise to be here in this capacity, but unfortunately, as you may know, Lurie was the victim of an attack last year, which he will talk about. And in the room, we have Syed Alam, who is the founder and CEO of accentedge, our partner in putting this program together. Syed and his firm work with dozens of health systems across the country, and also with lots of other industries on cybersecurity, as well as other kind of technology needs. And so he brings a really interesting perspective, not only within the healthcare industry, but across industries, as companies of all sorts and organizations of all sorts are grappling with the notion of cyber resilience. So I'll be moderating the conversation. We're using a platform to take any questions that you might have whether you're with us in the room or whether you're joining us virtually. Go to matter.socialqa.com. It's matter.socialqa.com. At any point to pose your questions, you can see what others asked. You can vote on their questions if you so desire, and I'll do my best to weave those into the conversation as appropriate. At the end of our discussion, Syed will share a few thoughts on what a resilient healthcare infrastructure looks like. Thank you, Syed, for putting this program together with us. I'm looking forward to hearing from you and from Tom and from John and from Scott. You all have so much expertise in this space. And Syed, why don't you say hello, and then we'll kick things off.
Well, thank you for showing up on this cold afternoon in Chicago. I mean, obviously, we are glad that you're here so we can share some of the thoughts that we have. As you know, healthcare is probably the most consequential thing that affects human life. It stands between life and death for humans, and nothing is more important. And what we have seen recently, in recent years, that has been held hostage by criminals, where they come between the doctors and their patients and demand money or demand things that we would not give them willingly. So we've been working with large hospital systems, and I also want to welcome Awais Hanif, who's the head of cybersecurity at Sinai Health in Chicago, one of the largest safety net hospitals in the United States, who we've been working with. So we've been working with hospital systems, as Steven mentioned, and there's been a lot of good news. There's been a lot of increase in investment. We have seen our clients increase staffing by quadruple, budgets by quadruple, but there's still gaps. There are still significant numbers of breaches that put patients, children at risk. And we took a step back a few years ago and we said, well, we need to change our strategy. We have been solving for preventing break-ins, but I think what we need to solve for is to prevent disruption, because that's really what it matters. When you stop the delivery of healthcare to a patient, to a child, or to an older person, or to a woman, or whomever it is, that's what the real problem is. And we need to prevent that as much as we prevent the break-ins. And that really, so we said, where are our examples of that? What are the industries that actually, where the disruption is unacceptable? So you look at transoceanic flight, where we put 500 people in a plane in New York. We don't just hope that it's going to land in Singapore. The manufacturer has to prove that even 3 of the 4 engines were knocked out of a 747. It will still make to the nearest airport. They have to prove it, otherwise they will not get type certificate. Power plants. We never notice when the power is disrupted because it continues. And we believe healthcare is the same thing. It is not, if not more important, but as much as those other things. And we looked at the design principles, and I'll share those with you today, that if we can implement that, we can solve to prevent disruption. And it's not a one-day thing. It's not a cheap thing. So we're going to talk a little bit about that. But that's the goal that we should actually strive for, in addition to preventing the break-ins. So I'll be sharing that. And I cannot be thankful enough to have Dr. Shanley here, Mr. Riggi here, Mr. G here, because everybody on this table, in this panel, they're not speculating. They have firsthand knowledge. They bring firsthand knowledge from the FBI, the CIA, the White House, the Secret Service, and Lurie Children's. So what you'll hear is a real understanding of the topic, and not some consultant, projecting. So thank you so much for this opportunity. We are doing it at Matter, where we have incubated our first solutions a few years ago for cancer detection, and can't be happier that we're doing it here.
Well, so glad to be working with you on it, and thank you all for joining, and thank you all for being a part of it and sharing your expertise. John, I want to start with you and ask you. You have a very wide and deep, but very wide lens on this entire issue, and bring us up to speed on kind of what's going on. How many hospitals were successfully attacked? I'm sure they were all attempted to be attacked last year, but successful attacks is the number. I think the number is going up. Is it going up? Is it going down? Do you have any sort of estimates of the economic damage, and is it any way to sort of characterize the human toll that the attacks take on an aggregate level somehow on either patients or healthcare professionals?
Yeah, thank you for that. Great to be here with all of you and really to discuss this pressing issue that faces every hospital in the country, whether they're small critical access hospitals in very remote rural areas or the largest multi-state systems. I specifically use those 2 examples to demonstrate those are the types and the range of hospitals that were attacked last year. So let's talk about some numbers. The numbers that I use to really kind of gauge the pulse of the state of the cyber threat against U.S. healthcare is to look at the government numbers. So the government numbers really relate to the Office of Civil Rights, where any healthcare entity, HIPAA-covered entity, must report a breach of protected health information to the Office of Civil Rights within 60 days. And as many of you know, that information is publicly available on their breach portal website. Some call euphemistically the Wall of Shame, where all these victim organizations' names are published. Now, the names, the organizations on these breaches, for instance, are really focused on data theft breaches. However, we know that last year, the majority of the breaches reported to the Office of Civil Rights were actually ransomware attacks, which were accompanied by data theft. Just a baseline here and level set on the definition of ransomware. That is malware, which encrypts networks and data, causing that disruption to healthcare delivery, as Syed said. It's very common, as Dr. Shanley will talk about, for internal networks to be shut down and then connectivity with the internet to be lost. The numbers as of this morning reported from at the Office of Civil Rights, we had about 590 reported hacks against U.S. healthcare last year, resulting in the theft or compromise of the healthcare records of almost 170 million Americans. Now, again, that's more than half the U.S. population. We have to caveat one breach alone, one hacking incident, one ransomware incident involving Change Healthcare resulted in the theft, compromise of the healthcare records of 100 million Americans. So out of that total, one breach, the Change Healthcare breach, was responsible for the theft of data of 100 million Americans. As we know, that was a ransomware attack perpetrated by a foreign-based Russian ransomware group known as Black Cat Alpha V. So when we look at the numbers a little more closely, we see that out of the 170 million, one pattern is holding true. The vast majority of these breaches have targeted not hospitals and health systems, but mission-critical third-party providers, business associates, and non-hospital healthcare providers. Unfortunately, when they do attack a hospital, it's very, very significant, causing that disruption and delay to healthcare delivery, posing a risk to patient safety and community safety. Because when your local emergency department is shut down or your specialty children's hospital, services might be limited or not available. That affects not only the patients in the hospital, but the entire community that depends on the availability of their services in local hospitals. So when we look at that, 93% of the breaches targeted non-hospitals, but when they do attack hospitals, traumatic threat to life issues. In fact, through the AHA's advocacy, we have had the federal government, the FBI, the White House, and the Department of Justice now officially recognize and prioritize ransomware attacks against hospitals as threat to life crimes. So they mentioned Russian ransomware groups. About 90% of them are the groups, the ransomware groups. About 90% of them are Russian, and they are based in Russia or in the area of influence and provided safe harbor by the Russian government. So as we're all working together, again, we have seen the number of breaches increase very dramatically. For example, in 2020, there are about 450 breaches, but most significantly, only 27 million individuals are impacted. So then you can see the number has skyrocketed. Ransomware attacks specifically against healthcare have jumped over 300% just in the last few years. So let me stop there and see if there's any follow-up. Back to you.
Yeah, thanks, John. I mean, I have so many follow-up questions, but I want to bring Tom in for, I guess, the inverse perspective, the different perspective of what it's like to live through kind of one of these things. I'll say, first of all, I know a lot of people have come in since I started. If you have questions, either online or in the room, you can go to matter.socialqa.com and ask your question, and I'll weave those into the conversation. We also have seats up front in case anybody back here is interested. So Tom, you lived through this high-profile nightmare of a scenario which went on for weeks and weeks and weeks. Can you just describe what is it like? And I mean, even, you know, you're the CEO of the system. Presumably you weren't the one who discovered that this was happening. Like somebody wake you up in the middle of the night and like, what's your, you know, did you feel like we've got this down, we've got a plan and you just push execute on the plan, or like, you know, like how does this play out in real world? I mean, you know, we observe it from a distance, we read about it and we think, wow. I mean, first of all, I want to talk about who the monsters are who do these things, but also, you know, I mean, it's a little bit abstract in concept. So
I'll try to bring it to life a little bit for folks, and I do appreciate the invitation, and I was sharing beforehand. It's not a chair that I am happy to be in, but it is a chair that I take responsibility for. The opportunity to be able to share the lessons that we learned as an organization and as a workforce so that others can learn from that. And so I guess to, you know, sort of responding to the initial event itself, I got to go, I'll take you all back first in terms of, you know, what John shared is our data that we've known for a number of years. And so, as I'm sure all your organizations do, we have an enterprise risk management process, and cybersecurity had been on the top of we pick out 4 risks for an organization that we want to make sure that we're mitigating against. And so we prepared for this, we thought, adequately. And I will say that one of the lessons we learned was with John. So John in his former role would come and do tabletop exercises for the organization, which we probably did about 3 or 4 years ago. And in doing that, it helps to uncover where you need additional preparation for what Syed was mentioning in terms of the ongoing operations. And so it's a very complex organization that's about primarily clinical care, but we also have a workforce that has to communicate, has to get paid. We have a research institute that has to report grants and file grants and those transactions. And so when we thought more comprehensively several years ago about business continuity across all of our missions, realized that we had some work that we needed to put in place. And so that did serve us extremely well. Our HR function, for example, we weren't sure we would be able to pay people 4 years ago. We were pretty confident when we went through some integration work. And so that was important. People want to get paid through a process like this. And so that was indeed the case. In part of that preparation too is a communication strategy from the cybersecurity team, right? And so, yes, I did receive a call about 4:30 in the morning that noticed that there was some activities within our system. I should disclose there are some things I can share, and because these things are all kept under privilege off period, there's some things details that you may be interested in that I won't be able to share necessarily. But we had signals from the technical systems that we have in place, and in the preparation as well. And again, for any organization, you want to make sure you prioritize the assets that you want to protect from a technical standpoint. So as John mentioned, the target for these things is always the patient data and your electronic health record. And so that was a key priority to make sure that we protect. And so given the concerns that we had within the system, we broke our pipes to our electronic health record, successfully preventing any access to our EHR. And so with that we broke our pipes to all of our communication with our personnel through phones, through internet, and of course, access to our technical aspects of it from the healthcare operations standpoint was interrupted. So in crisis situations, most healthcare systems have in place a process where they bring an incident command team together, which is a very polished team. We're actually part of the benefit of having gone through COVID and some other crises as healthcare systems. Those teams are pretty they're pretty nimble, and we come together pretty quickly. And you have to make some, so first of all, communications right away, right? So communications up to the board, communications to the workforce through emergency tools that we have through cell phones and pager systems to really try to give them information about what was going on. Because at that time of day is not an unusual time of day for us to go to downtime operations. We're often doing updates to our electronic health record in the middle of the morning. And so we actually had a workforce that was in the hospital that was used to pivoting to downtime. So when we got there, things were
Downtime meaning
no
systems downtime,
recording,
not
system downtime.
clinical
Yeah,
downtime.
system downtime. So flipping to paper charting, flipping to paper documentation, which is, we do for a few hours at a time, not infrequently. And so that was, okay. But it was really the transition, frankly, that we bring the new teams in and we sign off at 7 a.m, realizing there was not a lot of information. We were still discerning and information that we needed to share with them in real time. And so you have to make some important decisions right away around clinical care. And I think one of the important things healthcare systems have to determine is around diversion. Right? We're one of the only level 1 trauma centers in the city. And if we have a situation where we aren't able to provide that, we need to make sure that we're diverting emergency vehicles and other things out of our system. And so that right away, you start to do some additional scenario planning from what we had done during our preparatory time. And, you don't always think of these things all the time. And so you almost can't over prepare. I would say that's one of the aspects of it. And so the one challenge that we were facing from the standpoint of diversion was a certain protocol that requires an active blood bank. And our assessment was that our blood bank timeliness could be limited without access to the technology that helps facilitate that. We're through this whole process, one of the things that we're incredibly fortunate to be, even though we're independent freestanding children's hospitals, we do have our academic partnership with Northwestern University and the Feinberg School of Medicine and Northwestern Medicine next door. And just as we were good partners through COVID, in this particular situation, Northwestern Medicine, we reached out to their blood bank right across the hall from us and said, will you be able to provide this in the event that this occurs? And they were. And so it didn't necessitate us to go on diversion at that point. But then it's a matter of, understanding what has happened in terms of the technical limitations that our workforce has, how to address them and their concern, and how to address the community and the way to navigate that. So your preparatory aspect on a communication strategy is really important, but it still remains challenging when you don't have internet access, you don't have telephone access. You're working on pagers and a cell phone system, and even our internal system we took down temporarily from that aspect of it. So that's the acute reality of what you're dealing with in real time, frankly, on day one.
So are you able to share how they got in? Like, was this a ransomware attack or something else, or does that, or do you not want to talk about that?
Yeah, what I would say is that we're complex organizations. Health systems are very complex organizations. They have a lot of connections to third parties, as John mentioned. We deploy a lot of technology that has software access. We have regional partnerships. We have network strategies that have regional partnerships. So big complex systems like ours, and the bigger you get, like an Ascension, you have a lot of vulnerabilities just on the basis of how you're structured and what you do. And so as you think about your technical protection, right, and your processes that you put in place, you really have to be thinking comprehensively and broadly about that. What is public knowledge, and we've disclosed publicly, is that this was a cyber attack by a group called Reseda. John knows more about them than we do. And what I will say, as part of the communication cascade that we had built into our processes, was not a fear of the federal authorities at all, but an incredibly important partnership with them. And so reaching out to the FBI and reaching out to the intelligence community and ensuring they knew what was going on to us and with us, and getting them in place right away from a forensic standpoint, enabled them to be, I think, more effective. And just from a partnership standpoint, you know, you can't be embarrassed, you can't be ashamed. You've got to be open and transparent with them. And I will say through the process, one thing I've shared in other forum, a couple weeks into this, went home to my wife and I said, you know what, I'm never going to complain about paying federal taxes. They did, as John mentions, and Scott knows well, that what they outlined, I mean, it's a war. I mean, it really is a war. And the good guys on our side won this particular battle. But that was just fortunate. And an important component you need to do is get these folks partnered in with you right away.
So a couple follow-up questions on that, and Syed, I want to pull you in for a different perspective, but when you say you broke the pipes, I mean, presumably, you know, if like I was at home and I just unplugged the computer, like presumably it's a little bit more complicated than that. Like what does that mean to do that? And did you have all of that stuff set up in advance? Is that something that, you know, is common or that you'd recommend? Like, hey, you need to have a button you push and it just blows up all of the connections somehow, and like, what does that mean?
Yeah, I have to say I'm not the technical expert. Syed may actually have opinions on that more so, but it is not trivial when you disconnect the outside world to your systems. And you need involved in that. And so I can share some important partnership lessons, you know, are those connections into many third-party vendors, right? And starting with Epic as an example on the electronic health record, right? Our academic partners, both Northwestern and other partnerships, our regional networks, right? So we support in the primary care space, the electronic health record for a number of primary care practices. That's off all of a sudden, and actually trying to get that communicated to them in terms of their downtime activities and resources was challenging. And that's why I say when you have these regional network presence, you preparatory wise need to be thinking through those aspects of it. So you lose access to those things, and of course, understandably, those partners are worried about reconnecting to you down the road ultimately. And you know, Lurie Children's is a really great place with really great people who treat our partners really, really well. And our vendor relationships that are related to the way our people professionally interact with them through years served us very well in terms of that trust and being able to understand from them what they needed for us to provide them in terms of our system being cleaned, if you will. And that was important, but that almost took longer than getting our electronic health record back up and some other things from that standpoint. The other thing I will say in terms of the technical breaking, there's a lot of necessary rebuilding, right? That might happen depending on whether there's rebooting doesn't necessarily work. And so it really does depend on the technical disruption that has either occurred because of what you wanted to intentionally disconnect or what they may have placed in terms of malware and other things that you're detecting within your system. So, but the important component of working with a partner to have them understand what occurred and why you did what you did in getting that repaired is in the current privileged nature of these circumstances is extraordinarily challenging. And so there's so much attorney to attorney conversation that actually has to occur and be understood under privilege to be able to open that up. And the only, you know, and John, we're going to pivot to this later. The challenge around that is because of the risk of litigations, right?
Yeah.
And if you didn't necessarily have that risk of litigation, there could be more open, I think, transparent conversation between partners that otherwise gets really slow and hung up by the legal ramifications of that. And so that is one, we certainly didn't rely only on our legal team either. We have external experts in this space, and it was really a combination of this team and in combination with some technical third party. So all of this was prepared ahead of time. So we use a firm that assesses, is constantly trying to penetrate our cyber aspects of it. And so they were engaged. So that combination with the FBI combination with our internal folks, were able to understand and discern exactly what was going on in real time to be able to know when we were doing good to come back online.
One other follow-up from something you said earlier, which is, everybody had to operate without electronic medical records, which is like hard to imagine these days. Is like, how do you do that in a healthcare setting? And is that something you prepared for? Like, did you train, doctors and nurses and the techs and everybody else? Like, hey, if you don't have access to the electronic medical records, here's how you figure out what the protocols are. Here's how you figure out what the status of the patients is. Like, here's how you essentially rewind however many years. Like, is that something you also kind of prepare for in advance?
I guess I would say in part, but so really, really important just in terms of understanding the clinical decisions and operations that we were doing at the time. So the system was designed for us to have our backup systems, which we had in place, have 72 hours of data. So in most acute care situations, that would suffice. And when we met with the clinical workforce, starting with their leaders, we said, look, this is where we're at. This is a situation. If you feel uncomfortable, then then we understand that. Don't do the care. And so particularly in the perioperative setting and the types of patient population that in part which are quite complex, that we care for and have long histories, that was probably in access to their patient records was absolutely the primary reason that we deferred many of the operative procedures that we were doing. And anesthesia people knowing what the potential risks were, putting children to sleep under sedation or operating on things was probably the biggest reason that we did not do certain things. And it was also how we evaluated, where people send patients to us from all over, and how we evaluated our transport triage as well, whether we felt like this was something we could continue to handle well or not. I did also remind our folks that it wasn't that long ago. A couple of quick lessons. I practiced in the era without an electronic health record, and I don't practice anymore. But I did tell our amazingly talented practitioners, it's your eyes, it's your ears, it's your hands, it's your heart. That's what you have always cared for kids expertly with. Yes, we have loss of some technical aspects that make it easy to look at the images and make it easy to get the lab results and get the drugs to the bedside and document that and bill it. But that's not what the heart of care is. We can still do that. And they really embraced that significantly. The other thing about the workforce, very young workforce, right? All the health systems have a young workforce. So we have nurses in part on the front line that never paper charted at all. And there's this little bit of a generational difference in the nursing staff. Our senior nurses felt incredibly more valued during this period than in years, right? I know how to do this. Come, let me show you how to do this. It was fantastic. And the other thing, and this is thanks to Ram, the manual, never let a crisis go to waste, right? If you go on our floor and you walk around any healthcare system, you'll see a lot of people paying attention to a monitor, and you'll see a lot of people in rooms documenting things, and you won't see very many people in the room, and you won't see them talking, and you'll see them hand over their printout for the handoff. None of that was distracting. Nurses, we had nurses that met surgeons that they care for their patients all the time for the first time because they had to go up and hand off and talk. And I said, look, what I was around, and every day, the executive team rounded throughout the hospital and the system every day to make sure we were keeping a pulse on where the challenges were. And when we were communicating weekly through town halls, I said, what I've been observing if we maintain this and we get our technology back, I didn't say we're gonna kill it, but I said, you know, we'll be an amazing institution. And I shared in the prep work that we were doing, I still do my executive rounding weekly, and our nurses, some of them say, we want downtime back. We communicated better, we paid more attention to the patients. There's some lessons to learn about what technology helps support and advances, and what technology may disrupt a little bit in healthcare overall. So I think a lot of, you know, big challenges, but also some really important lessons learned through going through a system like this.
I mean, you could probably save a lot of money if you just unplugged all that stuff.
So I will tell you, so, right, we track our patient safety index, which is all hospital acquired conditions. We had among the whole fiscal year 24, the time we were down was some of our safest months we had. Safest months.
So interesting.
For hospital acquired conditions, and it wasn't because of reporting. We still had our quality safety team that does rounding all the time looking for problems. And so there's a lot of things that this experience made me think about in terms of the future of healthcare and ways we might be able to think about doing things more effectively and better. But I'd rather learn the lesson once.
Yeah, well, I wish you the most boring 2025. Given what your 2024 was like and COVID, you kind of, I mean, you know, 2025 is just all this can be for you.
We'll see. There's been a change in DC that might be a little
Unlikely
bit
to be boring. Syed, you know, you work with a lot of different health systems, and you also work across industries, and I would love your perspective and your thoughts on you know, what are the most successful strategies you see being employed, not just in healthcare, but generally, and what's different about healthcare? You touched on a couple of things a little bit in your opening comments, but you know, what is fundamentally different about the nature of healthcare that affects the ability to prepare for and the ability to develop real resistance from a cybersecurity point of view?
Well, and I want to start actually how we got here. So if you look at the history of the computers, they started in the 70s. So it's only 50 years. And it started as a hobby. And they evolved so quickly, and they're basically products that are feature driven. The camera has 10 more pixels, you know, this says that. The screen is 1 point in long or whatever. It's something that didn't develop with safety in mind, with redundancy in mind, and with resilience in mind. It's feature driven. It's like shiny objects. They sell us shiny objects. And what ended up happening is we have put our most critical systems on these products without really paying enough attention to the fundamentals of safety and resilience and all of that. So for example, in the case of airplanes, or in the case of all these critical systems, there are 4 fundamental principles. There's redundancy, there's distribution, there's encapsulation, and then there's ability to have fault tolerance, where they self-correct themselves. They have the ability to self-correct them. If you look at today's computers, and when we design systems, we don't put those things in place. Like, we don't say, okay, if this EHR, are we putting all the customers in one place? Then if somebody just broke 1 point for you, you lose all the customers. So there's no distribution. When there's an attack on an email system, it can spread to all the systems at the same time very quickly. It doesn't just limit to that. So we don't have those design principles implemented in other critical infrastructure in our computer systems. And that's why that proverbial 400-pound guy in the basement of their parents' house can actually download a free program and point to a website and it will tell you not only what are the vulnerabilities are on that website, but how to exploit them. So it is literally very easy to do that. So that's the general context. You look at how computers really are implemented today. and healthcare is no exception. No, healthcare is extremely, like Dr. Shanley was saying, it has the widest attack surface. We have IoTs, we have websites, we have vendors, we have all those things happening at the same time. So it becomes very difficult to actually protect it. So it's a very easy target for that. And then it is also the most prized repository of sensitive information. The doctors have your health information, they have your financial information, they have your demographic information, they have all that information is in one place. So protecting the hospital system, that's why it's very, very difficult to do that. The other thing is that hospitals are also very dependent on vendors for IoTs or medical devices. So they can say, apply this patch to this pacemaker. Because every time you change a medical device, you have to go back to FDA and get approval for that change. You can't just apply that patch. So it becomes very difficult to do that. So it is that, it's like a perfect storm of vulnerability that is happening in healthcare. So that's why we have to really look at it, how we can apply some of those principles, and that's what we help our clients. Let's say you start applying those resiliency principles, and a lot of that can happen because you know your inventory. The doctors or hospitals know their inventory on their databases, that what devices are where, what versions they are, where they're located, and all of that stuff. So they can start segmenting like other industries do, or like I said before, an airplane, if it has one engine knocked out, all the other systems will continue to operate, navigation, controls, all that, one engine will continue to do that. So what we help our customers is to start segmenting and saying, this is your inventory, this is where you're most vulnerable, and this is where you need to focus and prevent somebody to getting in. And if they do get in, to fail over to another system or stop them right there. We don't see that for most of the hospital systems. We just see that, like, if they cut one wire or pipe, that's it. Now, for a critical infrastructure, that's not a good design. But we have that. We have, I was just talking to Dr. Shanley. I'm like, treating cancer is hard enough. Why would you burden a doctor to worry about cybersecurity? These are the people who take a baby, premature baby that can fit in this hand and make sure that it grows to be an adult that's healthy. How hard that is, and we burden them with this. So I think we need to really take the position that we need to really start doing this so that we implement those philosophies that have been there for a long time. We just haven't implemented them. And other industries, for example, in emerging technologies, for example, autonomous driving, which is coming, right? So that requires a continuous connection. Otherwise, all the cars are going to crash into each other. If you lose connectivity to 5G for 1 second on whatever the street, Michigan Avenue, you'll have 80 accidents in a minute. So we have all of that. It's just that hospitals are very difficult to run from a profit perspective. It's very expensive for organization, and to expect the hospitals to actually fund those types of initiatives is very difficult. So we also see that our clients struggling with that. And I think that's where the role of the government, the policy, the Senate, the government needs to come in, and also Matter needs to come in to raise capital so we can have, the money to actually implement these fundamental changes into these systems that we are putting in at the hospital system.
Even if I can just wrap those two together. The original or last question regarding access to the histories, right? So I mentioned we had 3 days of that, but you obviously want the full record. And so to the point around redundancy, I'm not exactly sure why Epic hadn't thought of this before. But we said, geez, we've got our data, it's protected if we could, but we can't access it directly. But if we had a reproducible data set, that's our data. And so it took a while to push the data to that, but we were able to do that with them, and they were then able to give us access to it. So that was a big win, ultimately, to get, before our full electronic health record came back up, to actually have access to a redundant medical history. And so Epic, I think, for their clients is working on that strategy. And then in a similar way, it may not be doable by every healthcare system. But when you realize how many transactions are done electronically in both, well, 3 areas, right? Drugs and ordering and getting it to the bedside, labs, getting it labeled down to the lab and back results back up, and imaging. Those 3 areas were all manual for about 48 hours. And I remember going into the pharmacy, our internal pharmacy, there was probably 110 people, where there's usually like 8, trying to transcribe all this. And I have to give my chief nursing officer, Brian Stahula, credit for this. He's like, if all we need is access to any Epic system that we can take our 300 patients and put them enroll them into the ADT system and print labels. And that alone would be fantastic. So again, fortunately, that's why I say it may not be doable by every person that's proximal to a partner that has a commensurate electronic health record, but Northwestern, again, very gracious to be able to let us deploy their instance of Epic in a test environment. And we basically, if you know the details, it's called an ADT, admission, discharge, transfer criteria. We were able to then create our inpatient census and print labels. And that was a huge game changer very early on. There's no way we would have been doing what we did in the 48 hours for the month that we maintained our downtime without that kind of solution as well. And so taking those lessons and putting them into durable approaches in the healthcare systems are things that we're all trying to work through.
Right, and you're exactly right. And I think these are things that, like you said a keyword. Why didn't they think of that?
Yeah.
But when you are putting something, FDA is there. Why didn't FDA say, hey, Epic, where's the redundancy?
Yeah.
Where's your distribution? Where's the encapsulation? Because if there's 30,000, and these are innovations are coming now, where the data is being pushed to the edge. So if they break in, they'll have to break in every customer individually. They can break my data, but it's not going to be theirs. So, but when they go to FDA or when they go to somebody else who's certifying that, yeah, you can, because any product that's used on a human, for medical purposes needs to be certified by FDA. So I think those are the things that we need. And I know these are monumental tasks and they're not going to happen tomorrow. But I think the time has come for us to take a position that we have to put an end to this nonsense. That's it. It's not a discussion, it's a call to action. Yeah.
So John, there's elements of this conversation that are kind of frankly very depressing. On the one hand, Tom, I love that quality safety didn't go down. You had some of the best months ever. Sounds like at least some percentage of your workforce was actually happier during this because they were valued.
I would go.
Okay, I want to go that far. At least we're feeling valued in a different way. You obviously learned a lot from this. Hopefully, it's a much stronger organization, which I would expect of going through a nightmare like this. John, we talked about, Syed's talking about, in fact, it seems much easier to keep an airplane flying when an engine goes out and the avionics break than it is to keep a health system running. You think about health system generally, Lurie's at the upper relatively end of well-resourced, and I don't know what your margin is, but I'm sure it's still like low single digits. Health systems, it's not like health systems are amazing businesses generating tons of cash and they can afford to invest a huge amount in this kind of thing. They're incredibly complicated organizations. It seems like a very unfair fight. You described 90% of these groups are are, I don't want to overstate it, that they're Russian state actors, but they're at least Russian groups with the tacit support of the government. I mean, what should we be doing as a country, as an industry,
Yeah.
as a, and sorry, I realize I'm asking you a lot, but and also when you think about, you know, little rural health systems or Sinai that I mentioned earlier, Sinai Chicago is a huge safety net, you know, hospital. It does incredible work without extra resources. You know, you work with hundreds or maybe even thousands of the hospitals and health systems around the country. What should it look like? And I mean, I'm interested in a policy framework, a government framework, health system framework. So chew on that.
Okay. So I know we only have a few minutes left. I'll try to give you some high-level thoughts here, or else we could run a master class on all those points here and philosophy as well. Here's what Syed said, which is fundamental. It starts with the technology. Technology developers must embrace the principles of secure by design, which the White House has promulgated over the last year, which we strongly support. And we must understand that the primary responsibility for security of technology should not lie with the end user. It must be transferred back to the technology and software developers. Secure by design principles. There's lots of information out there but on the federal government sites, the key factors. We as consumers must employ secure by demand principles. So when we make our buying decisions, we should buy technology and software from those companies and organizations which have embraced these principles. Let the market drive this change towards cybersecurity. That's part of the issue there. And then really understanding all technology that we purchase right off the shelf, every new piece of hardware comes to us insecure by default. That's why we have to constantly patch. So we're starting from a losing position right from the get-go. In terms of the regulation, in terms of medical devices, the FDA has promulgated very specific requirements that require any new medical device or medical technology that requires FDA certification to be accompanied by a cybersecurity plan. Now, this is for new technologies submitted, new applications post October 1, 2023. That doesn't address the issue of all the legacy technology we have or new technology that comes to us that was approved prior to October 1. So we have to start there. And then within our health systems, we have to recognize we depend on technology to deliver care in every procedure for almost everything we do. So that dependency, very positive in certain aspects, it increases economic and clinical efficiencies. And technology, the use of technology in healthcare has saved millions of lives and really improved patient outcomes for countless patients. So then we have to be prepared for when that technology is no longer available. That dependency creates risk when that technology is suddenly unavailable. To hear about Epic, so I just want to clarify, generally it's not Epic itself which is attacked, it's all the electronic pathways to Epic which get disconnected to prevent the spread of ransomware in most attacks. But ultimately, we need redundancy for that. And we've been pushing on a national level with Epic and others that provide primary healthcare technology to develop what we call simply, and as you developed, Dr. Shanley, on the fly, a technology spare tire, a limited capability, emergency use only capability for these core technologies that we could use in an emergency. From a national policy perspective, we also have been pushing the federal government to say that when an entity like Lurie Children's is attacked by a very sophisticated criminal organization, but has associations and is at least supported by state government, it's really an unfair fight. In that we need the federal government to treat these attacks as acts of cyber terrorism. And really, this, in any battle, in any war, you have to have defense, that's our responsibility, but you have to have offense, and that's the federal government's responsibility. We have to go after the bad guys and degrade their capability to attack us. I'm going to stop there for a moment. Scott, you know, Scott's just joined us a few months ago, and he's been in the fight with us very much. And any thoughts there on how we're helping organizations through tabletop exercise go through this battle plan, this battle exercise?
Well, thank you, John. What comes out of our tabletop exercises with organizations is a lot of the lessons Dr. Shanley learned the hard way, right? In terms of having solid downtime procedures and having those things coordinated across the different parts of the hospital so that you can keep running and keep delivering that high quality patient care, even in the absence of technology. You don't want to do it for a long time, I understand, but as Dr. Shanley said, there are ways to, as he demonstrated, there are ways to do it and continue to deliver high quality care without the technology, but have a plan for when that technology goes south on you.
Right. And we also actually help clinicians understand the difference between business continuity and clinical continuity. Business continuity is generally when the tech folks are trying to get those systems back up and running and the business functions. Clinical continuity is a clinician's responsibility to develop those procedures. How do we conduct surgeries and transplants without the technology? What's our capability to do that? And how do we diagnose for other hospitals, a stroke patient coming in without any diagnostic technology, PAC system down, or deliver radiation oncology without a linear accelerator that needs an internet connection to function? That level of granularity must be identified for hospitals to have good clinical continuity plans. So I'll stop there. Thank you.
Yeah, I want to emphasize, I appreciate both their perspectives and actually, John, this is something John taught me or emphasized to me, is that it's the only example I can think of where the victim of a crime is actually punished and held accountable from a plaintiff standpoint. So we do hope that the federal government has some stance in terms of if you're doing a certain level of what is sophisticated protection of patients' data, and yet you still get attacked. Is there some ability to be relieved of the additional legal pressures that continue to come with all of these breaches?
You know, if I could add really quickly, that's a very important point. In regards to first, the legal liability, there is a law in the books. I'll cite this for your audience. Public Law 116.321, Public Law 116.321, that provides regulatory relief if in fact you're attacked and have enacted reasonable measures, recognized cybersecurity standards for the previous 12 months. The law says OCR is directed to reduce fines and give you a favorable termination of audit. However, there's no legal liability protection in that statute. The other statute about information sharing, so important to help Dr. Shanley recover and deal with the FBI. Healthcare victims, any victim of a cyber attack has full regulatory and civil immunity for cyber threat information sharing with the federal government. I'm not a lawyer. Direct your lawyers to the Cybersecurity Sharing Act of 2015. That'll encourage your lawyers to give you the green light to work with the FBI and help you recover. Thank you.
Well, thank you for what you're doing and also for sharing your expertise there and here. And Tom, thank you as well. We don't have a lot of time left. Obviously this conversation could continue for a very long time. But Syed, I want to just turn it back to you. Thank you again for helping to produce this, and if you have any sort of closing thoughts and words to add before at least the people in the room can adjourn into a reception.
Well, actually, I want to thank you and Dr. Shanley and John and Scott. I mean, I think I'm just an immigrant, you know. I mean, these are the people who really, you know, just such an amazing, you know, panel that have provided their knowledge, and I'm just so in awe of, you know, how much you do, all of you, and John, you know, Steven, you, about, you know, the healthcare, about all of that, and sharing that, coming forward and sharing that. I think I'm really, really thankful to Dr. Shanley, John, and Scott, and also for Steven too, for hosting this event. I'm I mean, what I want to close with is that we have the technology. We can still do a lot. We have the ServiceNow, we have the IMDBs, we know where our stuff is, and we have very, very smart people for us. I think what we need to do is we need to start taking a position that this is it. We're not letting it happen, and we're going to use our knowledge, our technology, and all of that to really make sure that the disruptions are not going to happen again. And once you take that out of the equation, there would be very few cyber attacks. So really, we need to focus our energy into that. That let's solve the problem. How do we prevent disruptions? How do we continue to operate? And I really don't think we have to think in terms of, okay, can we do it without paper? No, we have to take the position our systems will continue to work. That's it. Maybe at a lower capacity, but we're not going to, pull out pencil and paper. No, maybe we'll have reduced capacity, but we will continue to operate the way we already do. Our SOPs will continue to work, but we have to start. And I think what I've learned is that nobody cares until you make them care. So we are here and we put this together to make sure that people care. It's their healthcare. I never had to, thankfully, go to Children's Hospital of Wisconsin when my child had asthma attack. They didn't turn me around. I was very lucky. But I know there are children who were turned around, who had cancer treatment. That's not happening. That's what we have to really go for. And it takes money, sure, we'll get money, that's fine. But I think we have to, well, we really have to take that. No, honestly, we have to take this audacious position. We cannot live like that.
Yeah.
So.
Well, thank you all. Thanks everybody who joined us virtually. That kind of concludes this part of the program. For everybody who's here in the room, we're going to adjourn right over there and hopefully spend some time with each other, get to know each other, and talk more about cybersecurity. Thank you all.